and I will try to give my lecture regarding the relevance of LH during the follicular phase. So these are my conflict of interest. And really, before going to the presentation, I'm really happy to hear about follicles and oocytes and how many we need and what do we need to do. But in the end, we might forget that behind all these follicles and these oocytes, there is a beautiful mechanism. This hormonal control of female reproduction, the hypothalamic pituitary ovarian axis, is really beautiful because it's controlling all this follicular development, this folliculogenesis, this steroidogenesis, and it's the driving force behind this. We have the hypothalamus giving the pulses, the pituitary producing these golden gonadotropins that we manage to recreate in the lab and we manage to stimulate our patients. And these gonadotropins, LH and FSH, they are taking part in the follicular development, maturation of the follicles, and finally in the ovulation. And this control is beautifully done by nature. So nature works very well. The problem is that sometimes nature fails because either we intervene or because the patients are different or because the patients have differences. So we're talking about the LH and FSH deficiency, which if we go back to our books, we will think always about production. When we're talking about deficiency, it means that the pituitary is not producing LH, FSH, and that's why our patients are deficient. But if you take all these definitions over the years and you see what ICMART is telling in the end, or the recent definitions, deficiency might not be only production. It can be reduced action. You can have tons of gonadotropins, but they are acting differently in the final target. And this can be congenital, this can be acquired, but in the end, what happens is we have the deficiency. And what does it mean? Reduced or absent follicular development, which we count in the end, decreases estradiol levels. And what we see, how many follicles do we need? Or how many follicles can we get? Because in the end, seeing all this congenital, acquired, reduced production or action, congenital comes to us the typical hypo-hypo. We learn back to school, back to the early years in reproductive medicine, that this is congenital. But in the end, we can have genetic variation in our patients. The women that we treat are not the same because we know their studies talking to us about polymorphism or genetic variation in the FSH receptor, the FSH gene, or the LH receptor, which means that the gonadotropin has a different action on the final target. Or in the end, we have other causes of acquired LH and FSH deficiency. For example, functional, anorexia, age-related, organic, tumors. And finally, doctors. We treat our patients, but we can go to in iatrogenic transit deficiency of FSH and LH. Question. We treat patients. It's beautiful to see the pathophysiology, the hormonal control, the axis, but when it comes to everyday clinical practice, who are the patients that they're LH or FSH deficient, and what do we have as nomenclatures in our everyday clinical life? Well, iatrogenic deficiency. We give analogs, we block our LH surge, and that's an iatrogenic deficiency, definitely. Advanced maternal age. Patients, as Human told you very nicely, are different. It's different to have a 20 and a 40 years old patient, not only for quality of the oocytes, but for their hormonal profile. We have patients that, although we expect that we will respond very well, eventually they don't respond well, and they're the hyporesponders. And finally, the genetic variants. But this is what we believe. Let's go a step further. Different lifestyle. Patients with different exercise habits, with different eating disorders or different stress levels that can affect the production of your gonadotropins, and of course, coexisting disorders. So the deficiency of the gonadotropins in the context of ART can be different. But the big question is, are they the same? We're talking about FSH and LH, follicular stimulating hormone. Someone would think that this is enough only. Is it the golden hormone of human reproduction? Is this what we use to stimulate our follicles? Apparently, we all use FSH. We couldn't live without FSH. And if we see the two-cell, two-gonadotropin theory, we will understand that yes, FSH acts on the granulosa cells. It's the leading hormone in the early follicular stages, up to 2 millimeters, that it's the driving force from the conversion of androgens into estrogens. And LH acts only on the thicker cells. But if we see the follicular transition, as Human beautifully told you, in the late follicular phase, FSH might not be needed because you see, or it might be needed less, I would say. You see that LH, which is the typical hormone working on the thicker cells, works also on the granulosa cells in a synergic way with FSH, from early dominance, mid-follicular phase until the late follicular phase. And if we try to see what is happening with LH receptors, we will be surprised to realize that indeed, this is what we learned. The study by the group of Johann Schmitz told us that when you have follicles less than 5 millimeters, there are no LH receptors. FSH is needed in the beginning and in the most of the patients. But when follicles grow, follicles 5 to 10 millimeters express in 80% of their granulosa cells LH receptor. And actually, when we're talking of follicles more than 10 millimeters, we have an increase and a dominance in relation to FSH of the LH receptors. So LH hormone might be something that we overlook and we shouldn't overlook. Because if you ask me who are the patients who can benefit from exogenous LH, going back to books, what is what we learned? Congenital hypo-hypo. But is this the past? Is this the present or the future? I would leave it to the past because indeed, these patients need LH and exclusively LH because they cannot have a follicular development. But the future means that we have iatrogenic deficiency, which combined with other factors can really make your patient's LH level lower. Secondly, we have hyporesponder patients for unknown reasons that we don't know, and we have evidence showing that these patients with LH can benefit. We have genetic variants that patients are not the same in their profile. Let's face it, we have different patients, not only in their phenotype, but also in their genotype. And of course, we are living in the era that the patients are coming too late for stimulation. 40, 41, doctor, I'm still young. No, my lady, you're not young, and your hypothalamic pituitary ovarian axis works in a completely different way. So back to school, we learned that LH is needed in hypo-hypo, and we have seen the early studies showing that the higher the LH levels, the higher the LH dose in the beginning, the higher estradiol levels, and the higher number of follicles more than 10 millimeters. But this is not the only condition that LH levels are suppressed. We use GnRH analogs, and doctors, we are not nature. Nature and ovarian stimulation are different. This is what's happening when we use a long agonist protocol. LH levels are crushed, suppressed. This is what's happening when we're using an antagonist protocol. LH levels are quite good, but each time you inject, they're crushed. Each time you inject, they're crushed. And someone might say that this is not a problem because in the vast majority of the patient, this is not affecting, and this is true. But if you compare with nature, this is where the LH levels go during a natural cycle. And if we compare the follicular concentration of LH in a natural cycle compared to a stimulation study cycle in the study by Van Rolf, here you see LH levels in a natural cycle are 10 times higher compared to LH levels in a stimulated cycle during the follicular recruitment. So, do all analog cycles need LH? Apparently not. And we have seen this. If you're a clinician, you treat your patients, you see very well that with your recombinant FSH, you can recruit follicles in your majority of the patients and everything is working well. But I will reverse the question. Are all patients the same? If we have an additional factor, like age, like intensive exercise, like different disorders that can affect further the LH levels, could it be possible that this iatrogenic deficiency that we create can become greater and this can affect the patients that we're treating? Apparently, yes, because we see it in everyday clinical practice, that not all the patients can be stimulated well with recombinant FSH. For example, we use pre-treatment strategies. Oral contraceptive pill is something that we consistently use in Spain and not in other countries. And we know the whole debate about to pill or not to pill. Some people telling that the pill reduces pregnancy rates, others telling that the pill do not reduce pregnancy rates. And our experience in Spain is that it works very well. That's why most of the clinics work with pill to program the patients. But what can be the difference, or why do you think? Because it's a typical thing in Spain to use LH activity in many of the patients. My transition from Brussels to Spain was coming to a world that we use pill while we were not using it at all in Brussels, and we use LH while we're using it very few patients in Brussels because they were younger, free cycles, because we didn't use the pill. So what happens with the pill? Study published showing that actually LH levels for the oral contraceptive pill are significantly lower during the mid-late follicular phase compared to the control group, suggesting that that's the reason probably why we tend to use it in our patients and we have a better recruitment. But on the other hand, if we take out the doctor's factor, what we use, imagine that we take all the young patients and without pill, with light stimulation, without huge downregulation, are they gonna respond the same, or are there still patients that they are different? Because genetically they are different. And we have seen studies talking to us about variants in the beta LH, 2-point mutations in the beta subunit, which leads to an LH that has a very short half-life, less than half of the half-life of the wild type, and this is consistent with the normal phenotype. But the phenotype is not consistent with the action of the gonadotropin at the final level, because we have seen in these patient studies by Carlos Alvizzi, in 12% of the patients that they are carriers of the mutation, they are mutated for the gene, we see that they have significantly higher consumption of FSH compared to the wild type. And in the end, we have hyperresponders. We measure the EMEA. There has been a debate if it's a quality or a quantity marker. I believe it's a quantity marker and it calculates all the oocytes, but also all the markers, it will fail. And in several cases, it will fail largely. And we will have hyperresponder patients. And in these hyperresponder patients, what should we do? We stimulate the patients. Do we have any studies telling us that I stimulate a patient, I have a hyperresponse, and what do I need to do afterwards? A single study, randomized study that has been published back in 2005 by De Placido and the group of Carlo Alvizzi, had patients treated with 225 units of recombinant FSH in an agonist protocol. These patients, after 5 to 8 days of stimulation, have been evaluated for response. 130, half of them, beautiful response, excellent, what I would expect. But some patients have, I would say, in our experience, they are not half, they are less. I would say around 30% of the patients had an inadequate response. We stimulated them, and 5 to 8 days, they didn't have follicles, they didn't have high estradiol levels. And these patients further were randomized to 2 different strategies. Increasing the dose of FSH, which I would agree with Human completely that why do you need more FSH in these patients? They don't have so many receptors, they have more LH receptors, or giving recombinant LH. What was the result? Surprisingly different. Increase in FSH dose in these hyperresponders led to only 6 oocytes compared to the control of 10 oocytes, but the addition of recombinant LH increased the mean number of oocytes to 9, comparable to the level of normal response. And if we check the pregnancy rates, cumulative and cumulative ongoing pregnancy rates, you will see very low pregnancy rates in the increased FSH dose and an increase in the pregnancy rates in the recombinant LH, leading close to the normal response levels. So apparently, these patients may have a LH deficiency and these patients might be helped. And in the end, what do we have? patients that they are different from 1978, because at this point we're talking about tubal infertility. Now we're talking about women that they are postponing their fertility and they are coming to their 40s thinking that they can become pregnant immediately. And apparently, the axis is working differently. Study published showing clearly that the LH levels in the serum of these patients, younger patients, are significantly higher to the LH levels of older patients. And this also shown with the testosterone. And we know very well that LH plays a role in the intrafollicular testosterone. So apparently, although we believe that patients are the same, their phenotype, their genotype, their age, and of course their lifestyle is different. And we need to take into account, because adding LH in patients or in the ground cells seems that it can increase the LH receptors and the androgen receptors, and it can help patients that they have lower levels in their blood. So, do we have evidence that these advanced stage patients can benefit from the addition of LH? Early studies have shown this. Early studies in agonist or antagonist protocol have shown in the agonist protocol that this can work, increases implantation rates and clinical pregnancy rates. And the study by Ernesto Bosch has shown that this can increase significantly the implantation rates in women 36 to 40 years old. And a recent meta-analysis published has shown that yes, there is a potential that in these advanced age patients, recombinant LH can work. Question, but the big studies didn't show anything in poor responders. Of course, if you pull everything together in the same basket, older women that they have a very low ovarian reserve, that they will not benefit from everything. If you have 1 or 2 follicles, what are you going to stimulate? You will not find the difference. But if you have patients that make sense, yes, you can find the difference. So, to investigate the role of LH in advanced stage hyporesponders, taking into account the hyporesponders patients and advanced stage, we are conducting a randomized trial in which we randomize Poseidon group 2 patients, 35 to 40 years old, with a good antifollicle count or AMH for their age or for their condition. We're talking about more than 5 or AMH more than 1.2, that they had a previous cycle with low number of oocytes to 2 different treatment strategies. One would be the recombinant FSH, 300 units, and the other would be a combination with recombinant LH. We're halfway, let's see, we're expecting to finalize the results in 1.5 years, and it's a multi-center study that's done in Spain by 3 hospitals, 2 in Barcelona and 1 in Madrid. So, who could eventually be the patients needing LH supplementation? Let's try to think about it. Patients come to your clinic and we have an initial diagnosis. They are lower ART patients. What you have? No severe LH deficiency, FSH deficiency. Clinical profile. 27 years old patients, tubal factor infertility. Do you need LH? Apparently not. You can stimulate with your recombinant FSH beautifully, and you don't need any LH activity. You have severe LH activity, congenital, genetic, or some polymers that have been seen or acquired. Then apparently their LH is where it's needed. And when you start your control ovarian stimulation cycle and you do your patient clinical efficiency assessment, after you're done regulation, after your first control, then again you have the option to individualize further and stratify. Because if you don't have any severe LH and FSH deficiency, why should you add LH? You shouldn't. But when you realize that you might have causes of LH deficiency, then apparently LH can make a difference, as it has been shown beautifully by the studies of Ernesto Bosch in the mid-follicular phase adding LH. To conclude, ladies and gentlemen, and leave the floor open for discussion, what should we learn? Number 1, LH is an hormone that nature has elected to be part of the follicular phase. We should face it. This is what nature does. We try to use nature and not violate nature. And we need to realize that, as Human told you before, LH receptors are present and expressed increasingly during the follicular phase in the late stages. So, can we have patients with LH deficiency? Yes, but this LH deficiency needs to go outside of the concept of hypo-hypo. We are blocked with this hypo-hypo. You can have impaired production, but you can have impaired action, and it will have not the same so great effect, but similar effect, that you can have lower follicular recruitment. And the strategies of ovarian stimulation are undeniably associated with LH deficiency and need of LH treatment in some patients categories. What is our role is to understand the patient's profile. Advanced stage may impair LH production and action, and identifications of certain conditions with LH deficiency should be done prior to stimulation, during stimulation, and we need to modernize the way of stimulating our patients. You have heard that you don't need the super doses in the end of the follicular phases. Well, now you hear that apparently there are patients that they will need more and more LH, and this is your role as a clinician to identify it and give it to your patients. Thank you so much for your attention. I'm looking forward to it.
Professor Polizos, thank you very much for participating. Very interesting talk, stressing out the importance of paying attention to LH level measurements. So I don't want to steal the show. Questions from the floor, please. Anybody wants to ask a question? I do have one, again, while we're warming up. Obviously, part of the investigation of infertility, we use AMH and offer ovarian reserve. So the testing of FSH and LH becomes less and less, unless somebody obviously doesn't have regular periods when you would like to do it. So do you recommend that we should continue doing LH measurements in all patients prior to IVF? And do you recommend that we, in fact, should functionally test the LH molecule or the receptor prior to IVF?
Lovely question, thank you so much. So it's true that we are used more and more because of the volume that we have, that we don't measure LH. May I remind you that there has been a study by Brussels, for example, showing that low basal LH levels, if you use an agonist trigger, will lead you eventually to have a lower number of oocytes retrieved. So yes, I believe although we are going to the field that we're not measuring LH, we might be surprised by patients that they have low LH levels, and in the end you will not be able to stimulate well or get your follicles. It's something that we were using in Brussels. I think when I came to Spain, it's not so common. I say we need to individualize. We need to see our patients, but practically speaking, if I have seen many oocyte donors, I have seen many patients that in the end, despite the beautiful follicular development, you have very poor oocyte retrieval. And this means that let's go back to books and think about measuring LH. Regarding the LH receptors or the FSH receptor, I think there is a lot of speculation in their studies that in favor and against. It's not for the prime time now. I think we need more evidence into this, and we're doing one prospective study that we're taking other genetic variants. Let's see. I don't believe it's to be routine screening, maybe in the future, but we will see.
Thank you. Question from the back, please.
Thank you for another great talk. As good as we hope we are as clinicians, a lot of the things you mentioned that we should look for before we choose our stimulation isn't always obvious, the polymorphism, some genetic issue. So there comes an argument to suggest that actually if you give everybody a little bit of LH, you'll be counteracting those problems before you identify them, however good you are. One of the issues, though, is at the moment is that recombinant LH's price is prohibitive to do that in most countries. So my question is, what's the quality of data comparing the HCG activity in the urinary products to overcome some of those problems compared to the recombinant LH?
Thank you so much. Great question. It's true that there is evidence from both sides. It's a different affinity with the receptor, I think, but I don't know if it's a matter of price in the end or a matter of quality. There is not a head-to-head comparison, as far as I know, that one is better than the other. The affinity of the receptor would be different. There is the same receptor, LH receptor, but LH has a different affinity. And this might play a role. And we know very well that the HCG, the urinary form, it's leading always to lower number of oocytes. The big studies that have been done from the pharma industry comparing HMG compared to recombinant FSH has always linked to lower number of oocytes. So I don't know if you want quality or if you want quantity or you want both. So I'm not quite sure whether they are the same if we're talking about a combination of quantity or quality. They target the same receptor. They have different affinity and they lead to different number of oocytes, with HMG significantly lower number of oocytes. The choice is yours.
Thank you. Another question. May I just make an observation in relation to those studies? There was no bioavailability study done in terms of how much FSH reaches the female ovary. So all the studies mistakenly assumed that 150 international units of HMG will have the same bioavailability as 150 international units of recombinant FSH, and that was the biggest mistake, and I speak from personal experience of such a study. So I don't think that the lower number of eggs today could still stand, but I take your point, and you beautifully show that we try to mimic nature, but we're not that good, and there's no HCG in circulating in the female body in the follicular phase, so that's where maybe we need to acknowledge that. Thank you. Other questions, please, for Professor Polizos. Oh, sorry, there's some question here. In terms of efficacy, safety, and cost, why don't we suggest the addition, oh, sorry, this is the question that was asked, pardon me, thank you. What should be the dose of LH in ovarian stimulation in suspected LH deficiency? How do we decide how much LH to add? Do you have any practical advice?
The studies that have been shown, the two studies by Berger and actually the second one by Ernest Bush, have played between units of 75 to 150. It seems that the combination of 2 to 1 is enough, and I think 150 units of recombinant LH would be enough for these patients.
Thank you.
We're talking that it's not congenital, right? When we're talking about blood transfusions.
Other questions? Would you have any experience with treating patients with hypogonadotropic hypogonadism with IVF and outcomes, and maybe compare that with using pulsatile LH therapy and avoiding IVF altogether? Any comments on that? I know it's a bit different from the title of your talk, but I think it's a practical question. And people raise their hands up if they have seen patients with isolated LH deficiency, hypogonadotropic hypogonadism, low LH? Yes? Show of hands? Nobody sees patients like that? No? Okay, we have a few hands up. So who sends them straight to IVF? Nobody. So you must have treatments available in your countries. Okay. So, sorry, please go ahead if you do want to say a few words.
No, I agree with you, Edgar. I agree.
Thank you.
There are patients like this, and then you don't need to treat them, all of them
Yes.
in IVF. The problem is that sometimes you have to find the right cutoff how to stimulate them, because boom, they will boom sometimes, and you need to go to rescue IVF.
Yes, that's very true. Thank you very much. There's no other questions here. There are no other questions on the iPad. So thank you so much, Professor Polizos, for being with us today. We do have a panel discussion, so we look forward to seeing you a bit later. Thank you.